Yeah. Good afternoon, everybody. This is it's my pleasure to be here at the Pediatric Vascular Surgery collaboration. As you might all well know, Riley Hospital is in our Indianapolis. That's our big children's hospital. And when I started there in 1984, and being the only vascular surgeon for a time, I got all the pediatric trauma and usually iatrogenic injuries and those less than two. You know, all the catheterizations, ECMO and stuff. And so I learned a little bit about taking care of them. But I'll tell you, it's every time I walked in those rooms and you see that little leg that's blue and it moves okay, but it's blue, it doesn't have a pulse, you're thinking, oh man, you know, what's going to happen? And then we started to learn that you can heparinize them, they do okay most of the time. So I think, though, that it's been a real point of trepidation for both pediatric surgeons and vascular surgeons. And then I thought it was just opportune that a task force be put together that collaborated across both specialties, because that's really the way things are going to work in the future and should have all the time. And I must admit it did in our situation too, because I would do the vascular surgery and then go, oh no, I can't remember those IV fluids and little kids, I couldn't do that stuff. So it would always go back to Jay Grossfeld, who was there with me then. So we appreciate you all being here. Thanks for spending now your lunchtime with us. We suck up just about every other minute during the day, but we appreciate you being here. And you're in good hands with, with Dawn and John, and now I met David. So I met David on Zoom, but not in person before. So thanks everybody for being here.
Thank you, Dr. Dalsing, and thank you, Dr. Mills, who's also in the audience. And thank you all for being here. There's a lot of concurrent things going on at this meeting, which is really fun, but sometimes it can feel a little overwhelming. And so it really brings me a tremendous amount of joy to see so many people with us in person in this room. And we've got a virtual audience of vascular and pediatric surgeons also with us today on Zoom. My name is Dawn Coleman. For those of you that don't know me, I'm presently at Duke, new to the South, and spent 2 decades training at the University of Michigan and working there with some pretty phenomenal vascular surgeons. And I think what I loved best about my training was what I learned and got to experience really because of the practice Jim Stanley had forged as an incredible leader in this space. And it strongly shaped my early interests as a vascular surgeon, and I think defines a lot of who I am today. I got to meet John White and speak with Mike Dalsing frequently along the way as an early career faculty, and these kids are a challenge, and there are some of us who hear about them maybe more frequently than others, but I think everybody who has a touch point with these really special children appreciate that there's an unmet need or a gap that hopefully this task force will help us resolve together. And I'm going to just dive into a couple slides to overview some of the work this task force has done. I'm going to introduce my partners in this work, and then we're going to dig into some really interesting cases that I think are going to be fun to walk through. And we have a few of our task force members, Dr. Shahan and Dr. Eslami, with us today to kind of help, and we're going to get all of you engaged as well. So enjoy your lunch while we're talking, and again, thank you so much for being here. The green button, got it, thank you. Sorry. All right, so why is this task force important? It's probably important now more than it ever has been for these reasons. The first is that cardiovascular disease in children and adolescents is on the rise, and this is a very real population health threat. It once was that children would be diagnosed with hypertension as teenagers, and I think people automatically would assume a surgical cause of hypertension. And now we have a lot of overweight, sedentary, diabetic children getting diagnosed with a lot of cardiovascular comorbidities very early in life. And we are going to feel that as vascular surgeons, maybe not as teens, but we're going to see younger and younger patients with advanced cardiovascular disease. We also know that other pediatric vascular issues are uptrending, particularly vascular trauma, and some of this has to do with the public health crisis that we're feeling, especially with gun violence on the rise. And I'd also say that there is a paucity of guidelines and best practices that all of us feel in caring for these special patients. They slip through the gaps. And finally, we've observed over the years that there is absolutely membership interest and need evidenced by attendance at previous VAM sessions, but also a growing unmet need that our trainees are feeling progressively as the training paradigms continue to shift and evolve. As the ability to extend the lives of children improves, the incidence and nature of pediatric vascular problems is increasing. And so this work, I think, is important. This is an AHA slide that just highlights the incidence of hypertension, which is up to 15% in our preteens and teenagers. Risk factors being male gender, Mexican American race, and obesity. Nearly a quarter of our high school students are using tobacco. Over a third of our youth meet definitions for obesity. And the prevalence of prediabetes is nearly 20% in children aged 12 to 18. We also know that trauma remains the leading cause of death in children. Vascular injuries, thankfully, are still rare, approximating 1% of these injuries, but a major mortality contributor. And iatrogenic vascular trauma still remains the most common form of pediatric vascular trauma. There's been a significant decrease in the overall severity of injury and in-hospital mortality observed since 2006, paralleling the significant decline in pediatric vascular injuries due to motor vehicle collisions. And part of that is that policies have increased the protection of children, such as the adoption of car seat policy in 2006, having likely impacted survival by decreasing the severity and frequencies of these injuries. And as the most lethal vascular injuries are firearm related, sensible public gun safety measures will likely further decrease the mortality among this vulnerable population. So we have a lot of work to do at a lot of different levels, not just locally to optimize care on the ground, but also to think about these children when we think about public policy advances as we move into the future. Furthermore, most centers don't have a dedicated team for pediatric vascular cases. We know that there is variability in the care and the operative management of patients, depending on the institution and the available resources at freestanding children's hospitals compared to co-located hospitals. We know that there are pediatric trauma training gaps, in particular when we both look at our pediatric surgeons and our vascular surgeons. There are many centers that lack dedicated teams, and many of our vascular surgeons we know from prior published data don't feel comfortable managing pediatric vascular disease. So adequate vascular resources within freestanding children's hospitals, including equipment, support staff, vascular lab technologists, they're often not available. And that continues to strain some of these acute challenges. And so why should vascular surgeons care? And right now I say this to my vascular surgeons in the audience, and I'm also going to push this a bit towards our pediatric surgeons. We really all need to care. But I will say that vascular surgeons need to be capable of providing comprehensive care to pediatric populations. And there are knowledge and technology limitations for both of our specialties when we think of optimizing outcomes. Collaboration matters, and we can do better. As we continue to navigate the challenges that we experience collectively caring for these children, we'll have to think about the management of extensive vascular trauma, complex oncologic reconstructions, hemodialysis access and salvage, ECMO considerations, cardiovascular disease, and importantly, the diligent long-term follow-up that's necessary to understand natural history of pediatric vascular surgery disease. Our task force convened approximately 2 years ago, and we broke our group down into 4 working groups that have essentially prioritized which we felt were the 4 most critically necessary gaps to correct in caring for these kids, ranging from blunt and penetrating trauma to iatrogenic trauma, ECMO considerations, and dialysis access. And I've highlighted some of the short-term deliverables this interdisciplinary task force has performed as we've leveraged this team through this needs assessment to put together our strategic plan. And so these are our next steps. This is the inaugural Vascular Surgery Development Group meeting, and this is the inaugural development group meeting that captures both of our specialties. And so many of our pediatric surgeons are listening on Zoom. The APSA meeting was just conducted late spring, and they convened their stakeholders and found a subset of membership with an interest in this space. And our intention is to continue a quarterly cadence of this meeting moving forward with our 2 societies. We're going to be working intentionally to advance the educational resources available to our respective memberships, and that's going to be partly through this development group, partly through anticipated resources that we will be able to house those and be made available to both memberships. And we're very excited to propose that we'll be pushing forward a joint supplement between our JPS and JVS during the second quarter of next year. We're going to work towards academic collaborations that will be meaningful and optimize practice management resources for both of our respective specialties. And so I want to give tremendous gratitude to the SVS leadership, in particular, Dr. Dalsing, Dr. Mills, the collective strategic board, Ken Slaw, Riva Bouchan, and Mary Bodak, who have been helping us behind the scenes to make this all push forward seamlessly, and then the respective membership from our SVS and APSA that have been engaged with this work. I'm going to stop there, and I'd like us to move, if you don't mind, into Dr. Williams' virtual presentation. And so I want to make sure that Regan is with us. At Le Bonheur Children's Hospital in Memphis, Dr. Regan Williams is the medical director of trauma and the president of the medical staff. She is also an associate professor of surgery at the University of Tennessee Health Science Center and active in the efforts to improve trauma care at a state and national level. She uses hospital data to help frame community violence as a public health crisis and engage the community to help. And she's going to share with us now virtually, and then we're going to move into some case discussions. Thank you. Hi, Regan.
Hi, everyone. Thank you for having me. I'm going to reshare now that I've unmuted. Okay. Thank you for that amazing introduction, and also just the introduction of the task force, Dawn. It's been a real pleasure to work with everyone and really discuss the issues that both of our societies know that collaboration is the way to optimize our patient care. And I'm going to just give a case presentation that I think is really a great example of how vascular surgeons and pediatric surgeons can really work together to optimize patient outcomes. And then my background is from our APSA meeting. As Dawn said, we had a great couple of breakouts on pediatric vascular surgery at our recent meeting at APSA, and we've had great support from our leadership. So on to the fun stuff. This was a 16-year-old male who came in after a motor vehicle accident. He was a restrained front seat passenger in a high-speed MVA. He did have loss of consciousness, was non-ambulatory at the scene, and was mostly complaining of leg and hand pain. You can see when he arrived into the trauma bay, his heart rate was 104, his blood pressure was 112, respiratory rate was 40. He was actually fairly stable considering the amount of injuries and the accident that he had gone through. On a physical exam standpoint, he had multiple facial abrasions, his airbag had deployed, and he reported being restrained, though I sort of question that based on his injuries that you'll see. His GCS was 14. He was slightly confused, but could move everything and follow commands. He had decreased breath sounds on the right and was found to have a pneumothorax for which a chest tube was placed in the trauma bay. From an abdominal standpoint, he had very little abdominal pain, was complaining of left hip pain, and then because this is a vascular meeting, he did have good pulses in all four extremities. So from an ED workup standpoint, you can see over on your screen left is just his initial chest x-ray with his pneumothorax prior to chest tube placement. He also had a dislocated left hip, which was reduced, and so his pelvis x-ray just shows the reduction of that left hip dislocation, and he had a slight acetabular fracture. As many of our patients do, he went for CT scan. We don't normally pan scan all of our children. We're really try to limit radiation as much as possible. But based on his mechanism and his chest trauma, he did get a head, C-spine, chest, abdomen, and pelvis. And you can see here in the middle that he had a significant amount of hemoperitoneum. So he had a grade 2 liver laceration, a grade 5 splenic laceration with active extravasation. And prior to going to CT scan, he did have an episode of hypotension, which responded to blood and plasma, which we had in our trauma bay. But we were concerned that he might need more intervention. Down to the right, you can see the CTA of the chest, which revealed a thoracic aortic injury. This was a grade 3 aortic injury with a pseudoaneurysm and no active bleeding at the time. So based on this and his hypotension, he actually emergently, So that was our ED workup. Interestingly, we didn't initially see his aortic injury as we were so concerned about the hypotension and the blood in the abdomen, and that was actually called into the IR suite once we got up there. I want to use this just a moment to talk about how we manage liver and spleen injuries in children, because it is slightly different than what we do in adults. Our APSA group has recently updated the guidelines, and most of the stuff doesn't totally matter for you, but just going over to the procedure box, you can see that for patients with blunt liver and spleen injury, and he certainly had both, we're going to transfuse for unstable vitals or hemoglobin less than 7. So he got transfused. And then the consideration of angioembolization versus operative exploration really kind of depends on how he's doing and what we think his clinical course is. So because his blood pressure stabilized after 1 unit of blood, he was considered to be a responder. And based on these guidelines, went to interventional radiology for an angiogram and a splenic embolization. You can see just a representative image here. His whole spleen was embolized and there was no bleeding after that. And actually, while he was in the IR suite, we received report that he had a thoracic injury as well. So vascular surgery was consulted. I know that y'all probably know more about this than I do, but these are the most recent Society of Vascular Surgery guidelines on aortic injuries. And you can see that he had a grade 3, so an injury with a pseudoaneurysm. Based on the recommendations, TVAR really is the recommended repair. In the old days, we could do open, but the outcomes are much better for thoracic endovascular repair. And because he was a grade 3, that was what vascular surgery recommended. I will say that as a pediatric surgeon who deals with children of lots of different sizes, when vascular surgery called and said that they wanted to put in a stent, I had to pause just a little bit. We really worry about foreign bodies in children because they're going to grow, and what's going to happen to that stent, and is it going to migrate, and is it going to cut off the subclavian artery, and is that going to cause more problems? I did call my vascular surgeon to have that conversation. They assured me it would all be fine. And then luckily I'm on this task force, so I'd already seen the SBS guidelines that also recommended it. And he's 16, so he's kind of adult sized anyway. And so vascular surgery did proceed with a thoracic endovascular repair. The other thing I think is really important to note at this point is that I don't have the skill set to put in a thoracic endovascular stent. And so when we talk about the best thing for this patient, it would have been really hard to do an open repair of his thoracic aorta, considering his liver injury and his spleen injuries. He also had a clavicle fracture on the right, a dislocation of the clavicle on the left, and then that left hip fracture. So when you think about a multi-system trauma patient and how do we get him better and keep him safe and get him out of the hospital and back to his normal life as quick as possible, the best option really was an endovascular repair. And we are so lucky to have a partnership with our vascular surgeons at our adult trauma center, which is just 2 blocks away. They come over when we need them, and they're a great help. And they had did a great thing for this patient. On the right, you can see, so the left is his injury again. In the middle is just the angiogram with the stent deployment. On the right, you can see his CT after stent was placed. He had a little bit of a endo leak 1 week post placement, but 1 month post repair, you can see that has all resolved and he was doing well. So postoperatively for him, and I think this is an issue we talk about a lot with vascular surgery and vascular injuries, is do we anticoagulate and what does that look like? And then particularly, what does that look like in this patient who had already had his spleen embolized and also had a liver laceration? So he did receive some anticoagulation during his procedure. He was recommended to start on aspirin when stable. About a week post-op, his hemoglobin dropped. He had a CT scan to evaluate his stent, and it was noted that he had a little bleed from his liver laceration. So he actually went back to the IR suite and had his liver bleed embolize the left hepatic artery. That then stopped his bleeding and his hemoglobin stabilized. He was then restarted on his aspirin and was able to go home. Of note also, he had a small PE that was noted on one of his follow-up CT scans in the branch to the lingula segment. He was treated with Lovenox for a week and a repeat CT scan showed resolution and the Lovenox was stopped. So he had a little bit of a rocky course, but was able to be discharged on hospital day number 13 or post-injury day 13, which is pretty amazing considering the extent of his injuries. And in that, I just want to, again, thank you for allowing me to present this case. And I do think that it really highlights why we need to work together to optimize the care, particularly for all pediatric patients with vascular diagnoses, but in particular vascular injuries, which need to be addressed quickly and really need to be managed as a team. And I will be around at the end for questions. Thank you.
Dr. Williams, thanks for that. I want to poll the audience and at least ask for a couple questions before I invite Dr. White to present some clinical vignettes to follow. But how many in the room in that particular patient would have recommended a TVAR? Put your hands up. You got to commit either way. All right. Put your hands up if you would have recommended an open surgical repair. Okay, put your hands up if you would have recommended no repair. Okay, and let me ask a follow-up question to that. How many of you as vascular surgeons, because you're who I have in the audience right now, how many of you would have had a pediatric supporter, a stakeholder from some other discipline kind of working with you for that particular patient's care, either congenital cardiac or pediatric interventional radiology or pediatric surgery or some other non-anesthesiologist, if that makes sense? Perfect. Last question.
12-year-old.
Huh? Yeah, that's good. 12-year-old.
That was a 16-year-old grandchild.
Yeah. How many of you would have had a partner for a 12-year-old? Yeah. How many of you how many of you are at a center that has a children's hospital co-located with you? And how many of you support freestanding children's hospitals that are a drive away or you do locums for them or something? Yeah, so I think that's a really fascinating cohort that we need to think about. Who has questions for Dr. Williams? Any other questions or comments for that particular case while we have her? Dr. Arya.
Dr. Williams, thank you for that case presentation. In the instances where I've had to do TVAR in pediatric patients, I worked in two different systems. In one, we were able to easily sort of transfer patients between the two hospitals to get to a hybrid room to be able to do that. And the other, it required a mountain of work to be able to do that. Also, the multi-trauma issues kind of play in. So any advice on how to make that process as easy as possible?
Sure. So we are a freestanding children's hospital, and we don't have a hybrid room, but we have a pretty great IR suite that is inside the operating room. So it's pretty easy if you need, like I do procedures in there a fair amount of time. We seldom transfer our patients to an adult center. It occasionally happens, but we really try not to. We think that children are best treated in a pediatric trauma center for multiple reasons, some of which are not even medical. And so I think I favor really working with a vascular surgery team to make sure that you have all the equipment and supplies that you need so you can really adequately take care of the patients within the children's hospital. Because as you noted, the transfer is sometimes really hard. And in this patient, we would have had to deal, it would have been a long time till he got stented if we had to wait for him to stabilize so that he could transfer. So we've spent a pretty good amount of time making sure that we have good vascular coverage for these reasons, and then also making sure that they have the equipment that they need, which I think is a big deal, particularly when we think about endovascular repairs. So thank you for your question.
Thanks, Dr. Williams. Can I ask if there are any additional thoughts or comments from my co-chairs or task force members? No? Dr. Mills.
You don't want to get into the weeds, but I mean, what device do you use? So some of the bigger kids you can actually use now that they're dedicated trauma devices for adults. Some of them will fit with reasonably appropriate sizing in kids, but some won't. So I've only done 3. That's kind of a lot actually, because I haven't done any until I went to Texas Children's. But there are stent grafts that are approved for coarctation, but they're a little more complicated to deploy, and they're balloon expandable. They don't self-expand. So has anybody used those? No. And when I've done those, I've worked with our cardiologists because they've they do these tiny kids with aortic coarcts, and it just makes more sense to work as a team. So those kind of cases, I usually get them involved. But what's everybody else's experience been?
I'm going to ask Dr. Aslami, I wonder if you want to comment, given the work that you've been doing and the working group that you've been kind of supporting.
Adults, I mean, in a 16-year-old, we obviously use the adult size. But actually, lower down in the abdominal portion, when there has been injuries, I have used VBX in a younger patients where the aorta is rather small. So that's how we have dealt with that. There is no specific thoracic stent for pediatric except for the coarctation stuff that we don't have access to it. And if they're younger kids, then we get the cardiologists involved. But I have never had a situation like that.
Those for coarct, they can be gone. You can go back and treat them as the child grows.
That's right.
So,
Yes.
But I had never used one before, so I wasn't about to do that person. Cardiologist. Most children's hospitals, they're all working with all the expertise you should use it. These things overlap, especially. So I think the message is, even though we have a lot of the skills, when you're applying in a different setting, get other people that maybe apply a different device in a different setting, but have overlapping skills and expertise.
Thank you.
Alex Merriman from Children's Hospital of Philadelphia. So I've seen a couple of these T-bars put in really small aortas in teenagers, and if it's too small, the thrombose, and that's a bad problem. I had 2 kids. I put actually a Bimon in for a thoracic injury because I'm a little nervous to put a balloon expandable stent in for trauma, but there's no great options. I thought about that coarse stent, was nervous about balloon expandable. But I think this case highlights a good example of the limitations, especially as they get younger, putting a T-bar out there.
Thank you for that.
I thought it would probably worth mentioning, as to Reagan's point, the question that she took about the transferring the logistics of these types of patients. It's important to keep in mind that grade 1, 2, 3 aortic injuries, these are semi-urgent cases, right? These are not emergent priority number 1. Obviously, the head, the belly is number 1. So unless you have a grade 4, which would be the hematoma around the mediastinum extending up into the left subclavian artery, you really, that would be something that it would have to be prioritized. But other than that, you do have some time. And so I think it's worth noting. Also, we have used an iliac limb of a bifurcated infrarenal device before for a small aorta, but I've never used that balloon expandable.
Okay, last question, we're gonna move on, okay?
I unfortunately had a chance of repairing a grade 3 thoracic aortic injury early in my career in a 10-year-old whose aorta was about 10 millimeters or so. I can tell you, and I did put an iliac limb in because of the smaller size, but I just want to warn everybody, these aortas are extremely elastic. They expand like crazy. Maybe use an IVUS to make sure that you do a systolic diameter measurement and don't go by the CT scan.
It's a good point. Add a pitch for long-term follow-up. I learned something from the trauma session that many of you are here and maybe know a million things more than me, but interesting finding a progressive LV thickening, right, Alina? Then after stent placement, presumably due to stiffness of the neo-aorta. So just as a plea, we all talk about we need to have long-term follow-up, so please let's keep that on our agenda. Thanks.
So we started out easy with a bigger one, but the pediatric cases presented to a vascular surgeon become ever more complex. And so we're going to review a few clinical vignettes, and we have the great benefit of having Dr. Claudia Sheehan and Dr. Mohammed Aslami join us as experts to help us to work through some of these cases. So the first case is a 3-year-old boy who was in a motor vehicle accident in a car that was T-boned. He had some mental status changes requiring intubation, and he presented to an outside hospital. He was noted to have a left open humeral fracture with active bleeding. And the source of the bleeding was ligated at the outside hospital. And then the patient was transferred to the University of Michigan at the time. And The question now is, as you're on the receiving end, Mo, Claudia, what would you do? How would you proceed with this patient? It's been, I should add, it's probably since there was a transfer. At the time of arrival, it was probably about 5 hours or so after the injury.
So I use shunt first. You can use a pediatric feeding tube as a shunt, or a smaller argyle, like a carotid argyle shunt, and get the circulation going. And it's important when you put the shunt in there to do a gentle thrombectomy before you put the shunt in there, and make sure the shunt is in there, and then let them do whatever they need to do. And that's, of course, after using a lot of care supports, because you never want to deal with any pediatric trauma, but that's what I would do.
Yeah, I would agree. I think that, you would like to ideally primarily repair the artery if possible. You always would prefer to do that in a child. And if we were to do that after they stabilize the fracture, we would, especially in this age child, use interrupted sutures, allow for some growth potential in the future. If we needed to do a bypass, that would be the case, but we would have to explore that area. Usually the injury will be obvious, right near the area of the fracture. So you'll have plenty of x-rays there available in the room to help you if it's not obvious. Now with an open fracture, it's a little easier to just extend that incision and work your way down to the injury.
So how many in the audience would accept this patient in transfer with the plan of taking this patient immediately to the operating room? Okay. Would there be anybody in the audience who would say they would accept the patient but want to delay care using other forms of treatment, anticoagulation, et cetera? All right, so let's see how we proceeded. If you look at surgical repair was undertaken pretty much as our experts suggested, in that a shunt was placed with then fixation of the fracture. And finally, in this case, because of the ligation having to debride, a saphenous vein, reverse saphenous vein bypass was performed with interrupted sutures. No attempt was made to repair the vein at that time, but because of the long duration of ischemia, forearm and hand fasciotomies were performed. So if we look at the concept of trauma that we face as vascular surgeons, it is one of the leading causes of death for a wide variety of reasons. So as you can look at it, that it represents, mean about 1% of all pediatric injuries, but vascular trauma represents a high mortality rate. If you then look at a variety of hard and soft signs, you can see that there was really no difficulty in making the diagnosis and the need of repair for this patient we just presented. So once again, the repair principles, you can consider using a tourniquet proximally if you can safely without interfering with the orthopedic exposure. The microvascular principles do apply. So feeling comfortable with either high-powered loops or a surgical microscope is essential. Most of us would always use an interrupted suture line and then use a Fogarty catheter, 2 French, if it fits. And remember that the 2 French Fogarty catheters don't necessarily inflate slowly and directly. So I would encourage you, if you're going to use it, you want to, before you insert it, fill it and withdraw the fluid so that you get a more uniform expansion of the balloon. Doppler is essential. You can consider a completion angiogram. And these vessels are very prone to spasm, so Doppler signals may take some time to significantly improve. The use of vasodilators and anticoagulation are also essential. So let's look at, and we'll have a question and answer period afterwards. So we're going to just review these vignettes rather quickly to give you some thoughts, and then we'll take your questions. So if you look at the patient, this is another motor vehicle accident, but in a younger patient. The patient had infrarenal abdominal aortic trauma, a duodenal hematoma, hand fractures, lumbar vertebral body fractures, was managed at an outside hospital conservatively with repeat imaging in 1 week to monitor the aortic injury. And you can see here the area of dilation representing the aortic injury. So on the lateral, once again, you can see what appears to be a significant aortic injury, perhaps a small false aneurysm. The patient was transferred because of the injury to University of Michigan, and the CT scan was performed. Let's see, I'm not, there you go. Look at the 2 o'clock area of the aorta. So you can see that there's a small defect that you can see briefly. So the question now is, you have this 12-year-old, she's a week beyond the injury. She's had slow expansion of the degree of aortic dilation in the area of injury. Now, so let me turn it over to the experts. So what do you think?
Well, the imaging was a little hard to pick up on what the axials look like, but with an intimal injury, I would agree. You should watch these and see, especially if there's no evidence of loss of pulses distally, and watch the progression and then decide if it needs to be repaired. In this particular case, I couldn't tell really how bad it was because the wall itself doesn't look normal. But still, I agree on watching this one as well. This is an injury that I believe could be watched and should be watched. And then if it's getting worse over that serial imaging, then you can go in, if you need to repair any of the visceral, you would explore the bowel as well. I know there was a duodenal hematoma, but these are, the spine and aortic injuries are often associated with some type of intestinal injury as well, like a perforated viscus or torn mesentery. So I'd definitely look at my GI tract, and if I had to repair that, I'd repair that first, really irrigate out the belly real well before going into the retroperitoneum. And then we would do an interposition Dacron, if appropriate. You'd open up the aorta, look at, the way that aorta looks in that image, it's hard to know what it would look like inside a typical intimal injury. You can go in, you can look at it, transverse arteriotomy, you might be able to tack down intima, you might be able to do your repair that way, but I haven't ever operated on something like that. I think that for the most part, there's going to be a little bit more disruption and you're going to have to do some type of a repair. And usually we would do a Dacron interposition, small, short little bypass. But we might do a modified where we might be able to repair the wall with a patch. We've done that once before as well, and that's worked well in that particular setting where it was appropriate. But here it looks like it would be appropriate for a small interposition Dacron, just because of the conformational changes of the wall of the aorta looked very abnormal there. So more than just an intimal injury there. Anyway.
Thank you, Dr. Slamy.
I think it was nicely said. Because the repair is going to require, in my opinion, an open abdominal surgery, it's best to do follow-up visit and keep them, because there's a chance that he or she may heal the injury that they have. So initially, I agree with the follow-up, and then subsequently, as far as the manner of the repair, it all depends on, honestly, what you find in the operating room. You may be able to get away with the patch, or you may have to do an interposition graft with the Dacron. And if that's the situation, I'll probably opt to use a rifampicin soaked Dacron, just because there may be a micro injury to the duodenum. But that is just the way I do it.
I could also add, there is the potential appeal of wanting to do an endovascular repair for something like this. I forgot how old this child was.
12.
12, yes. 12-year-old still has a lot of growth to do, and so this is really not going to be ideal because of that.
Right.
It won't be a durable result. However, I would say also that if if this is a life-saving type of procedure, sometimes, you can do a repair that might be suboptimal for the long term with the idea that you will have to do a staged procedure later on as they grow. Because, if it becomes life-saving and that's your skill set. So it wouldn't be necessarily wrong. The other thing too is these injuries tend to occur at the aortic bifurcation, and so you really can't get away often with just a cuff, an aortic cuff or a limb or a single. It's usually a bifurcated that you need to implant. So there are really no commercially available endovascular aortic grafts for this size.
Very good. So how many of you would vote on a delayed procedure if necessary? How many would vote on taking this patient to the operating room based upon the information that you've been given? All right. So the patient was operated on, was found to have a more extensive aortic injury than was visualized on the films, and actually required an interposition graft to reconstruct the aorta. So now the question is, you have a 12-year-old young woman having an interposition graft. So to the experts, would you oversize? Would you use the aortic diameter as a guide? How do you choose your graft size? You've told us which grafts.
I would use the size of the diameter of the aorta. I think that Dacron tends to dilate over time, and if something is necessary later, you could always address that later. I think I wouldn't oversize it by very much. I don't know what the diameter is there. That looks like about a centimeter, so probably use a 12. And then the other thing is you could consider IVUS for sizing, but nobody would do that in this case.
Yeah, I agree that the Dacron, actually, when we were doing a lot of open aneurysm, Dr. Whittemore used to say you have to undersize what you do because the Dacron expands. So probably use Dacron and probably try to do maybe less running sutures. My mentor, Dr. Girone, used to do all of these things with few interrupted before started running. So maybe that's another thing to do at the same time.
Okay, thank you. And so we'll move to our last case. The patient was a 9-month-old with multiple birth defects, including 21 trisomy, ASD, VSD, AV canal, obstructive uropathy, who was admitted to our hospital 48 hours for evaluation of failure to thrive, dehydration, and acidosis. To monitor her and guide the resuscitation, a left femoral line was placed. For us, as vascular specialists, when called to see these patients, the information that we require from our pediatric colleagues is how many times they stuck the vessel. This really can have an impact on your repair. So it's how many times the vessel was cannulated, and then what did you put in? Fortunately for this patient, there was reported a single pass into the left common femoral artery, and they used a 2.5 French 5-centimeter arterial catheter. So after 8 hours, the leg is cold, loss of pulses distally, and the physical exam shows coolness, delayed capillary refill, but there was spontaneous movement of the leg by the child. The line was continued and duplex imaging was obtained, which demonstrated good flow into the proximal external iliac artery, but no flow detected distally in the external iliac artery, the common femoral, or the superficial femoral. So at this point, I would ask the experts, what would you do now?
Well, I mean, at this time, I don't think there's anything wrong with putting the patient on heparin and watching a little bit, because the patient has a spontaneous movement, there's cap refill, and there's a chance that, most likely there's a little bit more than a clot in there. If there is just a clot situation with anticoagulation, the kid may recover.
And the problem with operating, just going in and treating this patient like an adult, is that a 9-month-old's femoral artery is about the size of an angel hair pasta. And so it is tiny. I mean, it is almost impossible to operate on this artery. So you really want to do everything possible not to. Really try hard with anticoagulation and hope and watch carefully.
Okay. How many vote for anticoagulation? I think that's reasonable first step. So this is our acute ischemia protocol, systemic therapeutic heparinization. We monitor for spontaneous and stimulated movement, and we think that that's vital to give us a concept of neural health. And we put O2 sat monitors on both feet. And what you'll notice is that if the patient is getting into difficulty, the O2 sat monitors will indicate a drop in O2 saturation with movement of the foot, whether it's stimulated or not, indicating very low flow. So after 16 hours, the leg failed to improve and then became insensate and immobile without spontaneous or stimulated movement. The O2 sat in the left foot compared to the right fell to 87%. Now, how would our experts proceed?
You got to operate at this time. So you have to explore the femoral artery and plus minus embolectomy, and most likely there is a dissection or something from the axis. So that's what you got to do.
Yeah, I guess I would have to, most likely in this situation, operate too. I mean, does it look blue? I mean, even a blue leg in a baby will come back often. So, right. But if that's, obviously it's a reliable neurologic exam, so if that neurologic exam shows true neurologic injury, I think you have no choice. So you have to go in and explore the vessel.
The decision-making is, yes.
Just a comment, we, after being frustrated with this in recent years, we've paired with our left hand microvascular surgeons in these cases.
Right.
We are implanting digital vessels. We all go down to 2 millimeters, 1.5 millimeters of lesions by our practice. We kind of stop there. And we're getting a bit of the resolution within 3.5 meters. So that has been a real plus for us.
Yes.
It is a lot of success in this work in previously.
I would strongly agree with you. So this vessel, to keep in mind, your options, the vessel was measured radiologically at 900 microns. Now, remember, a 2 French Fogarty catheter is 660 microns. Not a whole lot of room for error there. So we like lytic therapy when we can for patients like this, but unfortunately, because of intracranial concerns, the patient was not considered a candidate. So we took the patient to the operating room, made a transverse arteriotomy. We're able to use a 2 French Fogarty catheter, but only in the iliac segment to begin movement of the clot. And then we remove the catheter, and we tend to use 27 gauge IV to suck the clot out. And we were able to get restorative inflow. Since backflow was present, we did not try to stick the Fogarty catheter anywhere it shouldn't go. We repaired the vessel with interrupted 9-O-proline and then did a 4-compartment fasciotomy. The patient did well through the operation with a blood loss of 5 cc's, which in an infant is a lot. But the blood pH normalized to 7.4. Unfortunately, the CPK rose to 36,000, right? Frightening level. So what would you do now?
What's the exam like?
Well, we took a look at the exam. The calf muscles look healthy now, bulging a little bit, but not a lot. The thigh is pretty firm.
Then you have to do fasciotomy of the thigh.
Yeah, something that we frequently don't have to do in the adult, but what we wanted to do is undertake a thigh fasciotomy, which we did, and fortunately, that was the cause of the elevated CPK, and the child did well. So that then we were confronted with a waxing waning vascular exam. So this child had palpable pulses, followed by periods of non-palpable pulses and low flow on Doppler. So now what?
Anticoagulation and watching.
Okay. Would anybody vote for reoperating on the patient at this point? Okay, so no, we agree with you. So we obtained an MRA. It showed a flap in the external iliac artery that was mobile and intermittently occluding flow. So we opted at that time for continued IV heparin and monitoring the oxygen saturation of the foot as well as leg movement, which both seem to be doing well. Ultimately, within 7 days, a common femoral pulse was consistently present. The duplex showed resolution of the flap and good distal flow, and the fasciotomy sites were all healthy and healing, and the patient subsequently did fine. So if you look at our particular experience, we would say that indications for surgical revascularization on iatrogenic ischemic limbs is the drop in ipsilateral O2 sats, drop in O sats with movement of the leg, lack of spontaneous or stimulated movement of the leg, and the absence of flow in the lower extremity on duplex exam. So these are the indications, and then the surgical technique you've heard about previously. I mean, it is challenging. So with that, again, we'll have a long question and answer period, but Dawn, would you like to introduce Dr. Rothstein?
Yeah, and so I'm happy to introduce Dr. Rothstein. Do you want to speak before we dig into, where is he? Where's David? Sorry, I'm behind this podium. I wonder if we want to discuss the cases before he digs into his content and at least have a little bit of a Q&A. What do you think?
Okay, so we'll open,
okay?
then, sure, absolutely. So we'll open the floor to questions about any of these cases at this point. Is there any information we can give you that will be of help to you if you face these cases? So while you're coming to the podium, you know, I would tell you that for aortic injuries in children, we have used stent grafts. It is my belief that they need to be kept as short as possible. So that if there is significant growth and that stent graft represents constriction, you're not faced with a massive aortic reconstruction. So we keep them short. We will frequently use aortic cuffs, you know, rather than a long stent graft. So that's just our word. So question.
First off, thank you, everybody. This has been excellent so far. General question about all vascular disease in children. In the adults, we have really clear guidelines and quality metrics that we should have everyone on aspirin and everyone on statin. Children seemingly probably a little bit different, at least especially in terms of a statin. Thoughts, questions about when to use them, when not to, dual antiplatelet in any cases? What do you do in this population?
I can at least share what my practice has looked like with antiplatelet therapy. And since the patients aren't getting surgical interventions for cardiovascular disease from atherosclerosis, I've not chosen to offer statin therapy to any of the kids I've operated on for trauma or other developmental etiologies. I'm very liberal with the use of sustained antiplatelet therapy, especially in the setting of any prosthetic. So lifetime antiplatelet therapy with a weight-based appropriate dose of aspirin. And I know that there's sometimes pushback because of the risk of Rice syndrome, but in, I don't know, 300 to 400 pediatric patients that I can at least propose we have data on from the University of Michigan's very long-standing history, I can't recall a single case in my exploration of older patients and in my own experience where that was a complication that we encountered. We've had one case of peptic ulcer disease that resulted in a bleeding ulcer in a teenager from sustained aspirin use, but that's it. And then there are a couple kids where they've had to have multiple reinterventions. And so we have opted for dual antiplatelet therapy in very select cases. And then the other thing John Eliason and I did over the last decade, at least, with some of these very recalcitrant, usually developmental etiologies for which we would perform an intervention that continued to fail from robust neointimal hyperplasia that would happen very quickly, is we opted to offer cilostazol for a 2-year period of time, usually after operation 2. And anecdotally, that seemed to work, but it was a finite number of cases and the data pretty anecdotal.
Simone, Claudia, anything to add?
Anything to add on that?
In general, hard neck surgeons, we use aspirin and water and or
Yeah.
So, I would agree with that. I'm more liberal with antiplatelet therapy. I hesitate with systemic anticoagulation, sending patients home on Lovenox, et cetera, for any long period of time, because one thing you have to keep in mind is children will be children. And getting in trouble when they're on anticoagulation is a real possibility. Yes.
Thank you all so much for putting this together. This is fantastic. Has anybody used for aortic injuries and reconstruction using the interposition grafts using a posterior aortic flap, or either from an iliac or from the healthy aortic wall, kind of similar to what some of the cardiac surgeons will do for coarctations and such, to allow for growth and development as these children age?
Nani, that's a really great question. I'll suggest that I've not done that, but I think it's a really intriguing reconstructive principle for select cases. I think the choice of conduit for these kids is really, really interesting to think through, and I don't know that there's a best practice. I will say the aortic case was mine, and I expanded from some of our mid-aortic practice to care for that patient. I think it's important to share a little bit of background about this 12-year-old, because she was an equestrian, very competitive, and had these non-surgically managed lumbar fractures, and so was going to be in a hard tortoise shell for about 6 months. It was really important to the family that she not have activity restrictions when that tortoise shell came off. And we went back and forth, and John Eliason and I completely disagreed about how to manage that aorta. And with shared decision-making, we ultimately opted to take her to surgery. And what we found was a fully transected aorta with the thinnest wall of adventitia left behind. And the intima had basically been transected with the media circumferentially and on both sides had retracted. I chose to reconstruct with 12 millimeter PTFE, not Dacron. And that's based on our mid-aortic data and decades of follow-up from Dr. Stanley's practice, in which we did see in the children degeneration of Dacron over time. Yep. The PTF has proven very durable. It seems to be at lower risk for calcification over time, which matters for reinterventions. And we didn't have any cases of graft infection in the series. And so we oversized because we didn't rely on that graft getting bigger. And when prosthetic is used, we'll often use a running suture line in those cases because you spatulate the native artery. And so I did just want to comment a little bit on that added discussion, because I don't know that we followed through why that patient was particularly selected for surgery. I know Mo Morsi in Little Rock has done some work using deep vein, so femoral vein, for some of these reconstructions, and I'm very interested to see what that outcome data looks like. I sense it's going to be much more durable in the intercavitary space than superficial vein.
Thank you very much.
Thank you. We had one of these and published, I think, the series of 4 a couple of years ago, and I came to make the same comment you made, which is we talk about intimal flaps, and when you get that compressive injury and you see that picture, oftentimes you'll see the more extreme ones where everything is prolapsed and it's starting to cause obstruction of the aortic bifurcation, and you go in and it's not the intima, it's everything shy of some adventitial fibers. And so it really is scary to watch that. And then having said that, our youngest one was an 18-month-old who came in with also duodenal perf and a kidney avulsed. We fixed that. There was bowel juice everywhere. The aorta wasn't expanding. And made the phone call to John Eliason when I got out of the OR and said, John, what would you do with this hairball? And 4 years later, we're watching him, and the activity is a real issue. How do you tell a 5-year-old not to have your brother punch him in the stomach when he gets angry at him? I mean, it is really a consideration, but he's had a stable dissection. I keep telling myself it's not the same process and it's a more minimal, it's just intima, but he has a stable, regular flap that has grown at the same pace as him. My hope is that eventually he's going to get out of it, but one of the things that this task force can do, I think, is to really bring together the tiny numbers from everyone's practice to try to glean some natural history on those, because I don't know where the right bifurcation is in terms of OR. He had recovery from contamination, so we were pushed out a while, but it's anybody's guess.
Thank you. Dr. Stanley.
So I have 2 comments. The first really is to emphasize what Pat Garrity said about using someone that's used to doing microvascular surgery. Some of you will remember Ron Furman during his presidential address at this showed a little girl who was probably 12, 13 years old, who when she was almost a newborn had both an iliac injury from a cath, but she embolized and really clotted off her popliteal vessel. and the plastic surgeons put a small vein graft in that. And I ended up consulting on this case later on when she was a teenager, and that graft was perfectly fine. The iliac reconstruction, which was done openly, didn't fare so well, but she was doing okay. So my thoughts are really about the aortic injury. Now, I'm not a radiologist, but I would have bet part of my lifestyle, my home and my kids, that looked exactly like a dissection. That looked like a rolled down sock, and I wasn't a bit surprised when Dawn mentioned that she had to put an interposition graft in. I have a different perspective than the two other panelists, other than Dawn. We stopped using Dacron. Dacron, by the time these children, if it's a traumatic injury, they have a relatively normal life expectancy. And besides the 20–30% dilation that we've all seen when these grafts are put in young, older adults, 40, 50-year-old people, and they get down 20 years, the lipid and sedation really makes these grafts very fragile. And we've tended to use PTFE. That's my first comment. So we would use preferentially, and I've been involved with 60+ aortic reconstructions using that, and I've not felt uncomfortable. If you have to do it on a 4 or 5-year-old child, you obviously are going to have a problem later on. You're going to have to revise that. But you have to have, 50–60% narrowing to cause a pressure gradient. So and we tend to oversize our grafts anticipating growth. So we don't put in a graft that's the same size. And the other is we don't use interrupted sutures when we sew a prosthetic graft in. That graft's going to be the same size as the orifice. And your aorta may grow, but that orifice is not going to grow. So we tend not to do that. But it's good presentation in good cases. None of this is easy. And I mentioned to John White earlier, there is zilch data on a perfect way to treat these kids. So, this sort of consensus opinion of what feels good and looks good in 1 or 2 cases may be enough to cause you to do it that way, because it's going to be a long time before we get hard data.
Thanks, Jim. Yes, Satish.
No, thank you, wonderful. I just want to bring to the audience 2 more fabrics, 2 more conduits probably we can think of instead of pure synthetic in some of the, like for example, you said there's a duodenal perforation and now we are worried about using a pure synthetic graft. So one of the things is a bovine pericardial patch that we use all the time for carotid. They do come in bigger pieces. The cardiac surgeons use it for some of their patches. It comes in 2 by 4 inches. So you could use that as a patch in quite a few cases. And you could even make it a tube graft of that, just putting over a chest tube and cow, and it can still become a tube graft. Number 1. Number 2, which we probably did not have a few years ago, are the homograft, the cadaveric homografts. They come in very small sizes. I was surprised. They come from 8 to 9 millimeter to 13 millimeters, the aortoiliac grafts. So something to keep in mind.
Thank you very much. All right, thank you. We'll go on to our next presentation.
Thanks, everybody, for the great discussion, and thank you to our panelists, Dr. Shehan and Dr. Eslami. I'd like to now invite up our partner in this work as a task force co-lead from our APSA partnership. This is Dr. David Rothstein. While he hails from Boston, he is currently practicing as a pediatric surgeon at Seattle Children's, where he is a professor of surgery at the University of Washington School of Medicine, and he has a long-standing interest in minimally invasive neonatal surgery, complex oncology, and ECLS systems issues. So thank you, Dr. Rothstein.
Good afternoon. Hello. Thanks for the invitation. And I'm just learning that you guys are all softies at heart, I can tell. So I'm going to move a little bit different, move along to more sort of systems issues. I mean, I think like a good prosecutor, I'm probably not going to tell you anything you don't already know, but try to express why this collaboration is so important. And it's not unique to vascular surgery. So, at pediatric surgeons, we are masters or jacks of a lot of trades. I don't want to say we're masters of none. That's super unfair. But, in my practice in Seattle, we have people that can do congenital diaphragmatic hernias. The colorectal practice is very specific, neuroblastoma. So there are masters of everything. But in a general pediatric surgery practice, as we expand our indications, it's hard to really be good at everything, right? And so our practice, we are operating sometimes on a -4-month-old to a 24-weeker to a 35-year-old sometimes, depending on what they're coming back to the hospital for. We operate in every part of the body. We operate for congenital, acquired, traumatic. And in fact, this actually, now that I'm looking at you guys, you must feel the same way, right? You may not operate on a 24-weeker, but you may get called about an aortic thrombosis or a vascular acquired or a vascular device associated IVC thrombosis. So you're going to be involved in some of these cases. And thankfully, I'm not operating in 95-year-olds as you are, but so we do have that in common. These are the 14 surgical specialties that the ABMS certifies now. So there's a lot there. Now, if you take away the 6 or so that have nothing to do with pediatric surgery, general surgery, we don't do ophthalmic surgery, we don't do gynecology specific, but these are in my view, these are 8 overlap places where we overlap in my practice or our practice in pediatric surgery. And if you add, I try to get a sense of when these specialties began granting certificates. And my point here is they may not be super accurate, but my point here is that until about 2 decades ago, the general pediatric surgeon was actually doing all these operations. We were doing colorectal, we were doing thoracic, maybe not congenital heart, although the first congenital heart operations were done by Drs. Gross and Ladd back in 1940 or 50 at Boston Children's. So, and even vascular surgery, of course, there were vascular surgeons way prior to the certification, but my predecessors were doing vascular surgery in kids because nobody else was doing it. So that's the last, up until maybe 2 decades ago. Now, of course, I love to present papers that you guys wrote. And again, this is nothing new, but the idea that general surgery residents, from where my practice comes or my field comes, have less and less exposure to open vascular surgery, right? So I trained 98 to 2003. I was telling these guys in Maine where we did a lot of ruptured AAA. So I saw that, I got the exposure, but I haven't thrown a vascular suture in years because that's just not my practice. Now, just as it is decreasing exposure in in general surgery residents, I think it's also decreasing in vascular residents, right? The integrated surgery residency may be doing less and less open surgery. So we were talking before about how you may not have as much experience in the younger generation of vascular surgeons in exposure. So there's more room for collaboration, but certainly going to do more surgery on the vessels than we are. This is from the ACGME 2020 minimal standards. Now, of course, it varies by program tremendously, but look, 10 anastomoses or endarterectomies, that's the minimal requirements for a general surgery resident. So basically, you can say that general surgery residents, for the most part, aren't doing a lot of suturing on vessels, right? And now only 20 pediatric surgery operations. So I'm not saying a general surgery resident should do pediatric surgery either. In our pediatric surgery fellowship, we're also seeing more training programs, fewer index cases per resident. So we are graduating residents or fellows with less and less experience. That's not every program, of course, but overall, I think we're seeing common themes to all of our specializations. This is where a typical pediatric surgery practice may overlap in specialties that are where adults have a lot more practice, even though they're children. So this is like in the last 5 years, I've seen a AAA. I didn't operate in that. I helped coordinate a vascular surgeon to come over and help us, of course. A Whipple operation, a pediatric surgeon may see this once in 5 years or 10 years. So we have adult surgeons who do these twice a week, 3 times a week. So why should we be doing these? And I'm saying we shouldn't be involved, but to be honest, if you put the patient at the center of the discussion rather than the pediatric surgeon, thyroids are an interest of mine, but I always did them with an adult surgeon who did 200, 300 a year when I did 10 or 15 a year, and a sleeve lobectomy in a thoracic case is pretty rare for us. So just in terms of what the collaboration can look like, the easy stuff is looking at these challenges. We talked about the decreased exposures. That just means we need to double down on getting experts in the room at the right time. Rare cases for us are AAA. Everybody has an anecdote, but we're not seeing these regularly. Renal artery hypertension, complex oncology. We're doing a lot of complex oncology, and we don't always need vascular surgery help, but it can be very, very helpful. Femoral ECMO, we're trying to expand the use of femoral ECMO because carotid access in a teenager doesn't seem to make a lot of sense. But femoral ECMO, we feel pretty comfortable cannulating, and yet I'm in a busy place at Seattle Children's. I have 12 partners. I may cannulate the groin once or twice a year. Is that expertise? Absolutely not. So our approach is we get on ECMO and then we ask our vascular surgeons to come over and help us decannulate, reconstruct as needed. We may be putting the stitches, but they're there to give quality control. Dialysis access is also, a pretty rare thing in pediatric patients. And we have sudden cases, so traumatic injury, iatrogenic injury. Now, it depends. Somebody mentioned before, this idea, do you have a freestanding children's hospital where the vascular surgeon is 2 miles away? In Seattle, that may include a drawbridge, so that might be 5 hours away, I don't know. Or do you have a co-located hospital where the vascular surgeon is across the bridge? Where I was in Chicago, that was the case. The harder stuff, not insurmountable, but, and this is kind of banal and mundane, but it's important. Freestanding versus co-located credentialing. In our current practice, we have to do emergency credentialing. It's super easy, but that's yet another little impediment. Billing, this is not why we do this, but you have to consider it because it is it's resource intensive. And believe me, if you're coming over to do a complex case, I don't know any vascular surgeon who's just gonna do that 2-hour case and then walk away. They're all gonna be as interested in the follow-up as you are expressing here. Call schedule as well. Where I am now, we have a call schedule for us. The vascular surgeons are covering other hospitals, and to add another call schedule is challenging. Dr. Quiroga, my partner here, knows that. And availability, it's the same thing. Yes, everybody in this room would bend over backwards to help a child, and yet you're on call for, other hospital there, and you're supposed to be rounding there, whatever it is. These are challenges that are not trivial. And so I think just like politics are local, I think every vascular surgery complex or construction or collaboration is local. So you need to know what your own challenges and resources are. Data-free zone or data-free adjacent zone, there's not a lot of data. We hope to, as part of our deliverables, start finding ways to generate more data, whether it's registry data or better database data, but we need to do more than just suggestions and what worked for me the last time. Lack of forethought, well, people in this room are thinking about it, and I hope we will think more about it, but even where we are in Seattle, where we do have a lot of need for vascular surgery, it's sometimes it's sort of like, oh, what did we do last time? How do we arrange this? Who's on call? How do we get access to the University of Washington call schedule? So it's usually you're asking the intern, were you on vascular last week? Okay, can you tell me who's on call? How do you figure this out? And lastly, let's be honest, there are egos involved on both sides. This is not a judgment, it's just we want to do what we trained to do, and it's hard to give up some of that. Again, if we leave the patient in the middle of the conversation, all this stuff gets super easy. So where do we go from here? Starting the conversation, we're here, but we have a lot of people at home with whom we need to continue these conversations. This is part of our deliverables. What's the scope of disease? What is pediatric vascular surgery, the disease? What are the diseases? Oh, is that like the hook? But we're not here to prescribe management. I think that's the art of surgery. We want to make sure that we understand that we're not, for sure, we are not telling anybody what to do. We're trying to provide data to help guide management. Education, that's part of this. It's part of APSA, our American Pediatric Surgical Association. We're trying to do more and more. We're going to be seeing this at our annual meeting, some devotion to pediatric vascular surgical diseases. Research, we talked about this, and the continuing kind of conversation at home. It's if you are in, especially if it's not a co-located situation, but even co-location, if you have the energy to find a pediatric surgeon as a partner, or my people on the Zoom call, I would encourage all of us to really think about what our local environment is and start these discussions so you can avoid some of the pitfalls or the delays. Know who the people who are interested, who are able and skilled. And then we'll leave more time for discussion. Thank you.
David, I really can't thank you enough for your partnership, and Regan, yours as well, and for making the long trip to be here with us for this meeting. I think it's really powerful. I do want to open up the microphone again for questions if anybody has follow-up comments or anything that they'd like to ask Dr. Rothstein. Dr. Shalhoub.
So I'd be remiss if I don't bring up genetics into this story. We have a lot of kids with genetic conditions, and I hear about the deaths, around the country when a kid with vascular EDS comes to the ER and they have a dissection that's unrecognized and they die in Children's Hospital. It's not an uncommon story. One just happened this past week. One happened last year. So I really would love to see that component addressed in this work that you're doing. This is tremendous work. I applaud the leadership. Thank you for doing it. And yeah,
We're on it. I promise we're on it, Sharita, and you'll be part of it.
Thank you.
Let me ask a kind of final polling question, but can you put your hands up if you're a resident or a fellow in vascular surgery? Higher, put them up higher. Okay, keep your hand up if you are actively getting any type of exposure to pediatric surgery. Good, that's actually more than I would have thought. Keep your hand up if you're an integrated resident getting exposure to pediatric surgery. Yeah, that's more like it. We have a lot to do, I think, to keep our workforce equipped with the skills and the judgment to care for these kids, and we have to partner at a local level. We're far more powerful as a collaborative team, but it also means that we have to be intentional about growing our own personal and kind of local divisional skills. And that's where I think we can help get stronger together and galvanize some meaningful collaborative work. And so there will be next steps that follow today's meeting, and we're very excited to work with all of you. And I applaud you all for being here and thinking about these kids. Thank you. As I said before, this brings me so much joy.
From Dr. Chow on the chat, what are the next steps we should be taking at our home institution? I think it's really reaching out to partners. I'm not sure if Dr. Chow is a pediatric or adult vascular surgeon, but I would find people, if you're new, find out what's been done. If you're not new, you probably know the history, and reach across it's not the aisle. We're all here with the same intent, but just to understand what are the logistic challenges. And really, for a very specific example, I was in Buffalo before coming to Seattle, and we had across the bridge vascular surgery, but we didn't know who was on call, so we had to work hard to get on the in the operating room board a vascular surgery schedule. It's easy, and then you know whom to call. There's just simple, small things to do, especially in trauma.
And I'll just add to that, I think at a local level, this practice, caring for children, I think takes a tremendous amount of resiliency and humility, and it's okay to ask for help. And John Rechtenwald also helped to train me, and for tough aortic cases, he always said, load the boats. And I would say for these children, load the boats like you would want your child cared for. As we move forward, we've got all of your contacts, and we'll continue to reach out through the SVS Connect platform to all of our SVS members, and our APSA partners are going to do the same. There will be a standing quarterly development group meeting in which we prioritize a clinical topic. There'll be leadership shared from both of our respective societies, and we'll look to you to expand on the prioritized clinical topics and themes that I shared at the start of our time together. I am hopeful that in addition to kind of an educational forum, a forum to discuss current data as it's available, knowing that it's limited, we'll also be discussing opportunities that will optimize local practice management, national policies and advocacy and practice management, and frankly, really meaningful academic collaboration so we can get better quality data to drive decision-making for these kids forward. So I ask you all to stay engaged. Please reach out to myself or Dr. White on the SVS element, Dr. Williams and Dr. Rothstein from APSA. And then some of you will be getting invitations in the near future to help us construct our shared supplement looking at pediatric vascular challenges, and we're looking to time that during the second quarter of 2024. So more resources coming soon, and on behalf of my co-chairs to this task force, I just thank you all for your time and your participation in the engaged discussion this afternoon. Enjoy the rest of VAM.